My first interaction with the Route 92 team was when Tony Chow, an intervention cardiologist per se, and Joey English, an intervention neurologist, brought to my attention this unique platform of a monopoint system, which we had been using it as a carotid stent kind of thing for a monopoint system. But as interventionalists who understood the procedural part of it and what was the deficiencies in the current armamentarium and the rapid strides in stroke care needed, when they brought this idea to me, in addition to another company asking me to do due diligence as a complete non-biased physician, that's my first introduction to the Route 92 HiPoint 88 system. I've been using the Route 92 088 HiPoint system for almost three and a half years now. I don't have the exact numbers on the top of my head, but more than 150 to 200 cases is where I am with the 088 platform system. And it's nothing been short of phenomenal in my hands over there. I was a belt and suspender, seat belt, everything, a balloon guide catheter, an intermediate catheter, a stent retriever. But given the simplicity of this procedure now with the Unipoint system, it's one and done kind of thing. So I have almost completely transitioned in the last few years to a complete 088 platform, from anything from the carotid bifurcation to the MCA bifurcation, any clot in that territory, it's 088. It has standardized a lot of our lab workflow also. The features which I like about this device are the catheter on the stick. This is the only device which is a catheter on the stick, which is 088, which is approved, FDA approved. And mind you, that's a big thing, FDA approved for stroke aspiration thrombectomy. This comes with the tensing catheter, which is an inner insert self-centering catheter. So what happens is, normally our challenge used to be bringing these devices up to the MCA. Would we bring the device? This has taken that would we to almost predictability, that we know this device will reach the MCA. The tensing will go through into the MCA, and over that, given the tensing has very little ledge with the 088, you can bring the 088 up into the MCA in almost very high majority of cases. When we looked at our data per se and our lab, and when we looked at two other labs when we published the SLIC data, 100% times we had no problem getting that 088 in the MCA. So from can we, it is we can get it everywhere. It's highly predictable in there. Like in our lab, in our hands, we know 100 out of 100 times we'll get that catheter up there. As a national PI for the Summit Max trial, I was honored and privileged to be part of this pivotal science moving paradigm shift. This is the first randomized controlled trial to date comparing the 088 with another aspiration system, the largest aspiration system to date available in US. So this actually moves the boundaries. This moves the goalpost in terms of how future science is going to be collected in terms of randomized controlled trials for super large bore. And I was honored to be part of that. As Summit Max trial, we enrolled about 250 patients across multiple sites, along with my co-PIs, Dr. Dabus and Dr. Nugent. And then we had phenomenal success. It was a rapid enrollment, and we met all the primary and safety endpoints. The primary endpoint was very interestingly kept as an FDA, where we have to look at modified TK2B or more as only with the study device. Any use of ancillary device was a failure. So the bar was set very high. So in those, we met with flying colors, almost 70% recanalization of TK2B and more with just the HiPoint 88 system was attained, as opposed to only 50% with the control arm. So that was a huge success in us showing that it is highly deliverable, and it's a TK2B, which is the physicians are comfortable with the TK2B. There's a good TK2B, so this was a very good TK2B where the physicians were saying this is very good, and that translates into looking at the use of ancillary devices. If you look at the ancillary devices, there was almost 50% use of ancillary devices in the control arm versus only 20% in the primary arm. In terms of safety, it met the endpoints. There was no increase in the safety events between the control arm and the 088 arm. Because as physicians who've been doing this long enough, we always kind of hear this, is this 088 is safe in the MCA? Now with multiple studies and studies across different devices, we have seen that the 088 platform is very safe in the MCA to do thrombectomy. When we looked at the secondary ad hoc analysis, when we looked at the top 3 enrolling sites, we were not surprised, but we knew what it is. There is a small learning curve. Like any new device, there is a learning curve. And as I said before, this is actually nothing like what we have been using in the past. It's a complete paradigm shift in how we treat with monopoint and a rapid exchange kind of system with the Route 92 study. What we saw with the highest 3 enrolling sites were there was more than 96% access to the MCA, as opposed to less with the sites which were coming up. In terms of the modified TK2C also, there was 68% modified TK2C, which is the first pass effect of excellent reperfusion. And the same translates when we look at the use of ancillary devices. From the trial study device, which was the HiPoint, it was 20% across the board. But when we looked at the top 3 sites, it was only 3% of use of the 3 to 4% use of the ancillary devices. So across the board, what it tells me is like once the physician gets used to it, this is going to get better and better and better in terms of navigability, getting the modified TK2C and above in first pass, and incredible decrease in the amount of need for ancillary devices. The Summit Max trial and the dedication to collecting level 1 data from Route 92 shows us how committed this company is to neurovascular care and expanding the indication of LVO and pushing the boundaries in a safe, ethical manner all the way to the MCA, and giving us a phenomenal tool in our armamentarium, which is going to be changing the paradigm how we treat stroke in the future.